So good evening, everyone. I'm going to go ahead and get started. Let me be sure I've got the right screen selected. Let's do this just to be sure. Okay, so our topic this week, medical disaster and public health emergency preparedness. I want to focus on just a couple of things. I want to focus on the just a couple of pieces about public health, and I know we've already had a separate session on public health, so most of it will focus on just the disaster side or the public health preparedness side, and then also the medical disaster and the healthcare preparedness piece. Again, just talking about different types of disasters and emergency management type activities that we do in the healthcare world. I will say the Joint Commission, which is obviously the accreditation organization for most all hospitals in America, there's over 100 standards that are a part of the Joint Commission component that focus on emergency management. So emergency management and disaster operations is a critical portion of something the hospital does. Sometimes hospitals don't always do that as well as they should, but particularly over the last 15 years in the aftermath of some more substantial disasters, such as Hurricane Katrina, a lot of effort has been made to strengthen the emergency management standards as a part of the Joint Commission. So just to recap what's due, I have a couple of small videos. I would encourage you to take a look at them. They're, again, short videos that talk about disaster planning, disaster preparedness, and drills or disaster operations in hospitals. And then there's a discussion forum that's due this week, and it deals specifically with the COVID-19 pandemic. Either review one of the articles, or I actually give you another option if you have a personal experience you want to share. And then aside from the discussion thread, there's also a quiz. It's somewhat short. It's 20 questions, but it's also short in time. It's 25 minutes. So I would suggest you take just a few minutes to refresh yourself with what's in the content before you take the quiz. I don't know of anything else that I need to talk about. Let me go ahead and switch to the presentation, and let me pull that here. Is the screen that you're seeing, is that the one that includes the primary projection, public health and emergency management?
Yes.
Yes.
Okay, thank you so much. So as far as our key terms go, there's a lot here, and some of this will segue into a presentation we have coming up. Actually, I'm not sure if it's a topic or if it's a supplemental extra credit as it relates to emerging infectious disease. But I'll talk at least just a little bit about infectious diseases. But as far as key terms go, HVA and THIRA are our two primary means of evaluating hazards and vulnerabilities, and I'll talk about that in just a minute. The disaster planning approach is something we do called an all hazards planning approach, and what that really means is whether it's, we don't have volcanoes in New Orleans as an example, but some of the same actions or activities that you would take if you were in an impact area for seismic activity associated with a volcano or floods or hurricanes, a lot of similarities exist regardless of the hazard. And so what we have kind of a base plan for our disaster planning, and then we develop specific annexes as it relates to things like hurricanes, pandemics, tornadoes, things that are more specific to our area. Obviously, we don't have a volcanic annex in our disaster plan, at least for most of the hospitals in the greater New Orleans area, but depending on what community you later work in and serve, obviously you may have a different annex as it relates to different parts of the country. Wildfire would be another example. Again, not really a threat that we have here in the New Orleans area, but if you wind up in California, Idaho, Montana, Alaska, some of those states that have substantial wildfire threat, that would be a disaster plan. A common plan that's a part of all disaster planning at all hospitals is surge. And surge basically means how do you absorb a substantial number of patients above and beyond what you would normally deal with. And so surge planning is really a critical element of what's done from a disaster standpoint at hospitals for something called an MCI, mass casualty incident. Our planning, so there's 4 primary components to disaster planning, and that's it's called the emergency management cycle, and that's the planning, preparedness piece, response, recovery, and mitigation. And then under certain circumstances, the word prevention also winds up being in there. Again, depending on what document you're using, in some cases, they talk about the 5th element of the disaster cycle, and that includes prevention, particularly as it relates to terrorism, which is a component of all hazards planning. But primarily speaking, it's the planning preparedness, which is one piece, response is the second piece, recovery is the third piece, and mitigation is the fourth piece. Again, I'll talk about those in more detail as we get into the presentation. We'll talk a little bit about plans and the planning process and resources. And then a gap analysis is really about what do you have, what do you need, and what's the gap between what you have and what you need. Response and responder safety. Responder safety is one of the most important elements that sometimes we don't always address as much as we need to, but it's certainly important to restore order and maintain a certain continuity of operations. When there's a level of lawlessness, it's very difficult to practice disaster operations and disaster management. When we set up and operated a field hospital in Mississippi after Hurricane Katrina, one of the things that we wound up doing very quickly within 24 hours of setting up our hospital was to establish a perimeter around the hospital, and that included armed personnel that were monitoring access points to the hospital. You know, one of the things you don't really think about in the aftermath of a disaster is some of the people that wind up evacuating are people who are supplying illegal drugs. And so if you're an addict and your supplier of illegal drugs has left town, sometimes the only place left to find something to get high, maybe breaking in a drugstore or confronting somebody at a pharmacy at a emergency hospital. We actually had some of that on several occasions, but again, because of our security plan, we wound up maintaining a perimeter of safety around our facility. But it certainly is important during a disaster and in the immediate aftermath of a disaster. I'll talk a little bit about infectious disease, from endemic, outbreak, epidemic, and pandemic, what those words mean, different types of infectious pathogens, whether it's bacteria, virus, fungi, or parasites, infrastructure stability. One key element of disaster planning is responder to victim ratio. And I say that because, again, the way we best manage a disaster is to push resources into an area as quickly as we can, to the point that we can have, once we get to the point that we have almost as many responders as we do victims of the disaster, it's much easier for us to control the elements of the disaster. When there's many more victims than there are responders, the few responders that are there become overwhelmed. Again, if you were alive or have seen some of the information of what happened during Hurricane Katrina, that was a great example of the responders being overwhelmed by not having enough response, not having enough support. The finance piece is certainly important. How do you sustain your fiscal operation during a disaster? In some of the early days of the disaster here with the pandemic, we saw some of the healthcare systems really struggle to maintain their financial viability for several months until additional emergency funding was implemented as a part of the CARES Act. And then we'll talk about Joint Commission standards and CMS standards as it relates to emergency management. So those are key terms. Again, we've talked about public health before, but the whole point of public health is preventing disease, prolonging life, and understanding the association of environmental safety as it relates to sanitation and public health. Early into the pandemic, we didn't have a cure. And today we don't have a cure. We have some effective treatments for COVID-19, but we still don't have a magic bullet cure, so to speak. And so the common things that we tell people to do from a public health standpoint, and I'm talking about physically maintaining a certain distance, wearing a mask when you're around others, and good hygiene, good hand hygiene. All of those are elements that, quite honestly, we've recommended for more than 100 years. Those are common tenets of public health. And I kind of get a chuckle out of some of the knuckleheads on Facebook talk about, well, flu is at an all-time low this year, and that's got to be because the government is trying to pull something over on us. Well, the reality is the same thing that spreads COVID-19 spreads the flu, and that's assembling in groups, not practicing good hand hygiene, not wearing a mask. Just the difference is we're not as concerned about that 2 years ago with the flu as we are today with COVID-19. And COVID-19 is far more transmissible, far easier to transmit from person to person than influenza. So, there is a reason why there's far less cases of flu today than there were 2 years ago. And for that matter, there were far less cases of flu last year than there were 2 years ago. But that's because, again, some of the steps that we've taken, many of the steps that we've taken to limit the spread of COVID are the same steps that you would take to limit the spread of any infectious disease, which includes influenza. And sanitation and its importance, again, from clean water to public health laws to protecting the environment. And again, that gets back to clean water and sanitation and issues associated with sanitation have dramatically improved the health and well-being of Americans and any other part of the world that has adopted good public health policies where they could or where they can. And again, from an infectious disease standpoint, one of the most frightening things in dealing with infectious disease includes, how did we contract the infectious disease? The influenza pandemic of 1918 is really the last worldwide pandemic that was far more catastrophic than what we're dealing with right now with COVID-19. Although I tend to believe had we not had the level of comprehensive supportive care that we've provided during the pandemic, I don't know that we would have lost hundreds of thousands of people like we did. Well, I mean, we still lost 500,000 people this year with COVID-19, but as a proportional relationship of the total population of the United States, um, uh, the death count, the death toll in 1918, I think wound up being about 5% of the US population. The mortality rate today is far less than that, although it's still going to wind up being the leading cause of death over the last 12 months, at least for citizens of Louisiana. I'm not sure what it's going to be like in other states. But for it to be more deadly than cancer and more deadly than heart disease, and more deadly than any other of the traumas combined, car wrecks, shootings, stabbings, it just reminds you once again that I think we've had more than 10,000 deaths in the last 12 months here in Louisiana. So it does give you an idea of how substantial this can be. HIV, so influenza in 1918 was really the last worldwide pandemic. Polio was it affected people differently, and there were many people who survived polio, but in some cases had sustained paralysis of certain parts of their body. President Roosevelt in 1932 was elected, and shortly thereafter was confined to a wheelchair because of polio, and remained in a wheelchair for the remainder of his life. And you notice the picture we have here, that's considered an iron lung. I'm not sure if I've talked about an iron lung before, but it's basically a large metal capsule that you put someone into, and it creates a negative pressure in there to help the chest rise and fall so that you can breathe. And you don't need to stay in the iron lung for 24 hours, but the idea is to allow you to stay in the iron lung for somewhere between 4 and 8 and 10 hours a day to help you breathe, and then that way it doesn't tire out what's called accessory muscles, because you've lost part of your ability to control muscles that help you breathe, the diaphragm, accessory muscles, things like that. And then HIV, although we still don't have a cure for HIV, we have the next best thing, and that is the ability to treat it in an effective way that even if you're, as long as the HIV is detected early, and as long as you maintain the treatment that you've been prescribed, you can live safely with HIV for basically the same expected lifespan as anybody else your age. The difference between that and the mid-1980s, in the mid-1980s, it was a death sentence. If you were diagnosed with HIV in 1985, as an example, in most cases you were told you've got about 6 months to live, you need to get your affairs in order, and you saw this just gross general decline over the next 3 months to 9 months before someone developed acquired immunodeficiency syndrome, which is AIDS, and died from in some cases, some type of a fungal infection, something that would otherwise be rather benign, but people were dying of really simple infections just simply because the body's autoimmune system had been overwhelmed with HIV. And so when we talk about public health or health system emergency management, again, a part of it is to look for ways that we can manage elements of the disaster. And then the type of disaster, it really is a part about doing an assessment. What's a risk assessment? I'll get into that in just a minute. But as far as why it's important, we've got to preserve the operation of our organization. That really includes the financial health. We certainly have to protect the employees and our patients, and protect the facility for that matter. And it's also important to be able to comply with standards, whether it's standards of CMS for participation in Medicare or standards associated with the Joint Commission. Stages of emergency management. So I mentioned this earlier. There's typically 4 stages. There's the planning and preparedness, which is really the largest stage. We do a lot of planning and a lot of preparedness, and really the response is just a a very short window of time in most cases. Now, the pandemic has been completely different, but with a hurricane or tornado, a flood, the response phase really starts with your first patient associated with the event, and the response phase ends when the last patient has been taken care of. And really the response phase in a disaster in most cases is a really short window of time. Um, and once you've made your last rescue or you've taken care of your last patient that's at least directly associated with the disaster, the recovery begins. And there's a couple of elements we kind of break apart: short-term and long-term recovery. I'll give you some examples. After a hurricane comes through, and we've made all of our rescues, our short-term recovery may be just getting some things working, um, being sure that the lights are on electrically. We can make cell phone calls by bringing in temporary cell phone towers, um, um, restoring general utilities. That's a part of the short-term recovery. The long-term recovery is building back the cell tower that was taken down by the storm. It's repairing the electrical infrastructure for buildings. It may be renovating the building or repairing the building in a way that's more than just stopping the rain from coming inside of the building. And then the long-term recovery, as I say, the short-term recovery is just what things do you need to do to be able to get by. If a window's broken out, putting plywood over the window. Long-term recovery is replacing the window. And then the mitigation piece is, there's something called an after action, and that's where you look back on the disaster and what could you do in the future to avoid this type of disaster. And that's what mitigation is really all about. It's what are things that we can do to avoid the disaster or minimize the effect of the disaster. And so again, we look at key points like what's the history going to tell us. And I'll get into HVA in just a minute. The science kind of help us understand how bad things are. Planning really helps us figure out where things fit into place. That surge is managing a large number of patients, much larger than we would typically get on a regular basis. Transportation is important because it may be helping people evacuate or moving people out of your hospital. It may be bringing patients into the hospital. And finance, how do you pay for it? I can tell you again, no matter what you're involved in the disaster operation, whether it's in the government side of healthcare or the hospital side of healthcare or a doctor's office, there's always some element of how do we pay for this. And rather than just glossing over that, I do want to be sure and hit that point. It is an important point. So HVA and THIRA. HVA is a hazards and vulnerability analysis. So actually, I've got a slide coming up in just a minute about what an HVA is. If you work in the hospital world, you're far more likely to do an HVA. If you work in the government world, you're more likely to do a THIRA. And a THIRA is a threat and hazard identification and risk assessment. And again, I'll look at those two in just a minute. So here's our hazard analysis. So with an HVA, we look at the hazard, and the hazard is something that's not in your control. The disaster history, what type of disasters either have occurred or threaten your jurisdiction. As an example, earthquakes there's a possibility that an earthquake can cause some damage to the New Orleans area. So there is an element of it being a hazard, but it's far less important to us than flooding and hurricanes, which are far less important, which are far more important than some of the other things that other people may deal with. Wildfire is an example. If you're going to work in a hospital in California or Colorado or Wyoming or Idaho or Alaska, wildfire would be big on your HVA. Earthquake would be big on your HVA. Those are really low components here. But on the other hand, flooding here is a big deal. Hurricanes here is a big deal. Tornadoes are a threat, but not nearly as much a threat as they are to places like Oklahoma, some parts of Texas, Kansas, Mississippi, and I'm talking about areas away from the coast. Northern Louisiana is more prone to, and if you wind up working in the Shreveport, Monroe area, then tornadoes are far more of a problem there. That's not to say that tornadoes aren't a risk in the New Orleans area, but they're far more likely to be less damaging than we see in areas that are that offer a lot more of a long flat area, again, such as northern Louisiana, Mississippi, northern Alabama, over into northern Georgia and Tennessee. Vulnerability is what you can control. So the hazard you can't control, the vulnerability you can. And so with vulnerability, you look at what are things that you can do to minimize your threat associated with the hazard. So if we know that flooding here is a threat, it's a known hazard, our vulnerability analysis is what are things that we can do to reduce the size of the threat associated with the hazard. And so as a city, as an example, if we know that flooding here is a hazard, our vulnerability is how do we increase the levee protection? How do we increase our pumping capacity so that we can pump water out of the city? Those are ways that we can help manage the vulnerability. There are a couple of hospitals in New Orleans that are certainly in flood-prone areas. And while they can't exactly go in and raise the building up, they can look at what type of services they provide on the first floor and hopefully move patient rooms out of the first floor and move patient rooms to the second floor. Now, if you're building back a new hospital, University Medical Center, the emergency department is on the second floor. There are no patient rooms on the first floor. And in fact, if you take a little tour of University Medical Center, you'll also find that there's actually places to tie off boats if it came to that in terms of being able to arrive at the emergency department. But that's recognizing the vulnerability of the city. I'm sorry, that's recognizing the hazard threatening the city, and then how do you identify what your vulnerabilities are and what are things you can do to help mitigate against those vulnerabilities. As far as academics, if we're involved, what are things that we can do? One of the most important things we can do is to data analysis, do our research, at least for hospitals or healthcare systems, help people understand the history, what type of frequency at least has occurred historically, and then are things changing, such as as the climate continues to change, will that increase the frequency of some of the storms that we see, or the intensity of some of the storms that we see? And then scalability. What can we learn from small events and apply that in a scalable way to larger potential events? So let's kind of look through a handful of historical disasters. In the aftermath of World War II, our first concern and our first threat was really the threat of nuclear attack from the Soviet Union. And so the response to that on the government side was to build out a number of 200-bed mobile hospitals with the intent of having all of these mobile hospitals around the country. So let's see. If I look at Louisiana, let me look at Louisiana. In Louisiana, there were 31 of these field hospitals. There was one for training, and so the total number of pre-positioned that were available for immediate use, there were 30 hospitals. And again, just to put this into perspective, 1,930 200-bed emergency hospitals were distributed around the country with the intent of, if there was a nuclear war with the Soviet Union, we would have field hospitals that we could build out. So my whole point here is in the aftermath of some type of disaster, or the threat of some type of disaster, for 75 years, we've looked at what the hazard was and what our vulnerability was, and looked to come up with solutions for it. Now, most of these emergency hospitals, actually all of these emergency hospitals, have since been disposed of. In some cases, they've been replaced with other types of emergency hospitals, but we're nowhere close to 1,930 pre-positioned disaster hospitals today. Earthquakes, just to again, if you wind up working in and living in particularly the west coast of the United States, but there's also substantial tectonic activity, and there were a series of catastrophic earthquakes in the Memphis, Tennessee, close to south of St. Louis, in 1811, 1812. And that's called the New Madrid Fault Line. Actually, if you're ever in Tennessee, close to Memphis, and you see a number of large cables attached to the underneath of bridges, those are actually earthquake cables to help. That's a part of their seismic activity preparedness. But nevertheless, this gives you an example of just how catastrophic this can be. And although it's kind of tough to point out, this building is clearly intact. This was the VA hospital, and this building is clearly intact. Just understand there was a building about this size here that completely collapsed and claimed the lives of nearly 50 patients and employees at the time it collapsed. This was another hospital that was affected by the same earthquake. And this hospital had actually just opened within 45 days earlier, and was touted as earthquake proof. One thing I'll call your attention to is this piece here. This is actually a stairwell. Here's another one leaning, where after the earthquake it's partially detached from the hospital. And we'll look at just a couple of other quick pictures here. And then the Northridge earthquake in 1994. The advantage to the Northridge earthquake, again, it occurred just north of Los Angeles, but the one advantage is it occurred at 5 a.m. Had the earthquake occurred at 10 a.m. instead of 5 a.m., it's believed that many more people would have been injured and potentially killed. The big deal there, though, is 11 hospitals wound up being damaged or needed to be evacuated. And so it's not just a matter of okay, we identified that there are basically 1,000 patients that need to be transferred. That also means we've lost the ability to take care of 1,000 patients, and we have to find a hospital for this 1,000, the 1,000 or more patients that need to be evacuated from these 8 hospitals to go to other hospitals. So, earthquakes pose a substantial issue in the fact that we typically do our disaster planning with the belief and the hope that the hospital will survive the disaster. But when it doesn't, we have to also think about, what are we going to wind up doing? Where do we take these patients? And what do we do with the patients we already had? The 9/11 attacks also gave us a substantial amount of understanding of how much absorption we needed to do. But again, when we think about terrorism, sometimes this is what we think about. Really, the first school bombing recorded in the United States was 1927. This gentleman to the left really disagreed with how much the school board was taking out of his money in taxes. And so he killed his wife one day, and the next day went to the school and had placed a number of explosives throughout the school. Um, um, and then additional terrorism. This is the Murrah Federal Building in Oklahoma City, 1995. And then if we look at terrorism, whether it's Kehoe and the Bath School bombing, or the Murrah Federal Building, or the Timothy McVeigh in the Murrah Federal Building, or Eric Rudolph in the Olympic Park abortion clinic bombing, the important thing with terrorism is, again, that's the prevention piece. We can't, from a disaster standpoint, from a hospital standpoint, all we can plan to do is how do we deal with patients that arrive that may be affected by something like this. You know, and although when we thought about the 9/11 attacks, the one piece that isn't often mentioned as much was, so the 9/11 attacks were really foreign international terrorists that got airplanes, over commandeered airplanes, and flew them into buildings. Well, shortly after the 9/11 attacks, anthrax, which is a bioweapon, a weaponized grade of anthrax, um, engineered from a lab, was sent to the Senate Hart Building. It wound up in different TV stations and newspapers, and killed, I think, okay, so actually I've got it on my next slide. 5 deaths, 22 cases, but really scared the crap out of a lot of people. And the reality was with anthrax, so let me see if I've got, yeah, these are different headlines from the anthrax letters. 6 postal workers treated, anthrax confirmed in New York City. It killed an elderly patient in Connecticut, found in an offsite White House facility. So there were thousands of tests, and it came from just a very small sample. But the big point to this is, from a disaster planning standpoint, how much do we plan for something like this? The main thing that we come to understand about, again, this eventually was determined to be actually a research scientist who felt like, as a country, we weren't doing enough to be prepared for bioterrorism. Now, officially, the FBI has closed the case. He was never charged. He wound up dying by suicide as the FBI arrived at his home to carry out a search warrant. But again, the reality of this is, what are things that we can do for potential scenarios like this? Although the likelihood of it is small, there is an element of planning and preparedness that has to be considered at any hospital, and that includes how to plan for and prepare for terrorism types of events. Weather disasters are far more likely, fires and pandemics, and so they're a lot easier to get people to buy into. You know, again, back to the terrorism piece. You know, the one component there that is practiced at hospitals on a somewhat regular basis is called decon, and that's, you know, what type of processes do we have for decon, and whether it's you know, something like anthrax, or it's something like a hazardous chemical. The point is, there is a preparedness component of that goes into the operation at a hospital in terms of disaster planning, disaster operation. So let's start with infectious disease just a minute. The types of germs that can lead to disease. Bacteria, there are a lot of different types of bacteria. The main advantage to bacteria is we have a lot of different antibiotics as well. And so most bacterial infections we can manage, and we have pretty good treatment mechanisms. We can't treat all bacterial infections, but we can treat most of them and manage them reasonably well with antibiotics. With viruses, we have very few antivirals. We're far more likely to be able to treat viruses. The best way to manage a viral outbreak is through vaccination. We eradicated smallpox virus through vaccination. We basically eradicated polio virus in the United States through vaccination. And that's the same situation with COVID-19. It's a virus. The best way for us to manage a virus is through developing vaccines quickly and using them. And that's hopefully, if you've not been vaccinated, now's your chance. Please be sure and get your vaccine. Fungi and parasites are a lot more rare, but also they're a little bit easier to identify and to kill. And we have reasonably effective treatments for people who wind up with fungal infections or parasitic infections. And so those are easier to manage. Fungal infections, parasitic infections, and bacterial infections, we have effective treatments for those. We have effective cures for those in most every case. Viruses are a different story. We struggle to treat and to cure viruses. We don't have a lot of antivirals. What we do have, in some cases, just don't work on every virus. And so we wind up just using supportive treatment. And again, our best approach in dealing with a virus is to develop a vaccine for it. Other words that you'll hear about an infectious disease is once a disease exists permanently in a particular region, such as influenza is endemic in the United States. It's seasonal. You're far less likely to contract the flu in June and July than you are in October, November, and December. But it is endemic. It exists here, and it's in the natural evolution of replicating itself on an annual basis. And so our best way of managing influenza, again, is through a flu vaccine and then good public health measures. An outbreak is when something suddenly occurs in a community. An epidemic is when it spreads through several communities, and a pandemic is really an epidemic that's on a global scale. A pandemic also usually includes something that's novel or unusual, we haven't seen before, and is easily spread from human to human. An example would be Ebola did not become a global pandemic, although we did wind up with some Ebola cases here in the United States. Europe wound up with some cases, but it was far more likely to be found in Africa. But it wasn't easily spread, and in fact, Ebola is spread only through blood or body fluids, and so that takes close and in some cases intimate contact to be able to transfer the infectious material, and so it's a lot less likely to spread that disease than COVID, which arguably is either airborne or at least through coughing particles or sneezing particles. The point is you can contract it without touching another person, but by being in their immediate proximity while they're coughing or sneezing or off-putting of the virus. And again, the single biggest threat to man's continued dominance of the planet is the virus. We do know that. Coronavirus has, again, kind of reminded us of that. This is actually from a chapter in a textbook that I wrote a couple of years ago, but it does remind you of what a pandemic is. These are the key elements. Now, I will tell you, the book published in 2014, I actually wrote the chapter in 2012. We really foresaw in 2012 our next pandemic would be, we thought it would be influenza. So that's why when we talk about a novel virus, we're more likely to talk about a novel influenza virus. SARS, today we refer to that as SARS-CoV-1, and COVID-19 is actually SARS-CoV-2. It's very similar. but it's obviously not exactly the same thing. And SARS, COVID-1, there's also a Middle Eastern version of it known as MERS coronavirus. Those are the three human coronaviruses: SARS-CoV-1, MERS coronavirus, and SARS-CoV-2, which is also known as COVID-19. Those three human coronaviruses are three of the more deadly human coronaviruses. Now, there's approximately a dozen human coronaviruses. Most of them just give us a head cold, and it's no big deal. But these certainly are a big deal. We really thought in 2003 that our next big pandemic would be something that was referred to as bird flu, and that's a bit of a misnomer. Almost every influenza is a natural host is birds, avian host. And so it's not uncommon for birds to have any variety of flu. And the most common flu is an H1N1. There was a particularly deadly variety of flu that emerged that was only transmitted from an avian host to human and was not easily transmitted, required a lot of close contact, but occurred in 2003 and 2004. And the main thing that was really concerning about it was it had a high mortality rate. In some cases, 20 to 30% of the people that contracted that version of the flu died from it. And the real concern was how quickly could this flu change from the vector of bird to human to allow humans to infect other humans. And if it did make that change, we felt like that would be the next pandemic. And that really led to pandemic and all hazards planning, which was a law that came up. I'll go over that in just a minute. One of our in terms of worldwide pandemics occurred in the 14th century, 1347 to 1351, called the Black Death. About 60% of the European population died during those 4 years from the bubonic plague, also known as the plague. But it was a bacterial infection. This is actually what a plague doctor wore during the 14th century. And yes, it is real. This is their idea of PPE, but it actually makes a little bit of sense. It covers all parts of the body. They wore gloves. When you hear the phrase, "I wouldn't touch that person with a 10-foot stick or a 10-foot pole," that's actually what they're talking about, is the plague doctor using a stick or a probe to tell the patient where to move to or how to move. This is just a picture from the 1918 influenza pandemic. But really our greatest threat here historically has been hurricanes. These are the 4 hurricanes that impacted Florida in 2004. And again, just reminding you, this is actually one of the disasters that I spent a lot of time in Florida on as a part of my disaster response with FEMA at the time. But other parts of this, again, just the same disaster that you see here playing out in Florida is very similar to some of the things that we see here in Louisiana. 2005, the national planning scenarios for disaster planning and disaster preparedness, although it wasn't intended for this to be released to the public, it's out there. And so let me go ahead and show you what Homeland Security in 2005 saw as the 18 most substantial national planning disasters that we should plan for. Again, it's a Homeland Security look, so their first concern is going to be terrorism, and that's someone being able to detonate a 10 kiloton improvised nuclear device. Again, the potential for that is very, very, very small, but the impact of that is dramatic. And so, again, a part of this is trying to weigh through what of these things are real versus what of these things are, well, they're all real, but the likelihood or the probability of them occurring. This is a national planning scenario from the viewpoint of the Department of Homeland Security, and it really is heavy into terrorism. Not that major earthquakes or major hurricanes are certainly not terrorism, but it does recognize their importance also in disaster planning. And then Hurricane Katrina, again, just a couple of images. These are some of my pictures from Mississippi. I never wound up in Louisiana as a part of my response to this disaster. This is from Waveland, Mississippi. I spent about 2 months in Waveland after Hurricane Katrina. And, after Hurricane Camille in 1968, which also came ashore at almost exactly the same place, they built a new hospital about 15 years later in Bay St. Louis, and it was the highest point. And if you'll notice where that's at, how far that is away from the ocean here, and then let's look at what happened with storm surge associated with Hurricane Katrina. So that's inside of the hospital the night before, and that's where the storm surge pushed water all the way over. So again, I get back to this picture here. All of this area became underwater during the storm surge associated with Hurricane Katrina. And so this is inside of their hospital. This is the water now at the doors too, and you'll notice the cars out in the parking lot. At this particular point, look at the water level outside the windows of the hospital. At this point, they've moved all of the patients from the first floor to the second floor. They had discharged most of the patients. I think they had a census of 7 people who they felt like were too sick to move. So they were not discharged as a part of the pre-planning before the hurricane came ashore. And then this gives you an idea of how they've lost containment of the flooding inside of the hospital. And again, the water out in the parking lot. The main reason I included this picture, other than showing the car underwater here, this was actually the building where their emergency power supply, their generators were located. The roofs have been blown off, and obviously all of this is underwater. So they don't have any emergency electrical power because it's all underwater. And as the water began subsiding, you can at least see where the water lines were in this patient's room, how much flooding occurred in the patient's room. Now, again, they were able to evacuate all of the patients from the first floor and move them to the second floor. And when you want to make the case for electronic medical records, you can also see debris on these, the leaves are on these medical records of where the water level in here has been, has basically flooded most of these medical records. And then this is actually our command group, a couple of people from the Army, a couple of physicians that were involved in DMAT. This is me about 15 years ago, a couple of my assistants from emergency services, and then she's a colonel in the Air Force, and they were the ones that we ultimately turned our hospital over to. And then this was the field hospital that we set up. And we saw a total of 21,000 people, about 7,000 people that were treated at the hospital itself, which is here. And then either out in some of these tents or here, we wound up giving another approximately 7,000 vaccines and another 7,000 prescriptions. And then this is the hospital at Bay St. Louis. And again, the main point of this is to understand that a part of disaster planning is understanding how bad things can be. Hurricane Katrina really helped us understand how bad things could be. You know, and Memorial Medical Center, which at that time was a tenant hospital here in New Orleans, was completely surrounded by water. And the really difficult part of it was, you know, again, you've got water rising in the hospital, you've got patients that are stuck in the hospital and really can't evacuate. And so they were able to evacuate some out by helicopter. They got some out by airboat, but it was obviously a very difficult situation. Challenges, they had a 246-page emergency operation plan that had no guidance on how to deal with a complete loss of power or how to evacuate the hospital if the streets were flooded, which really tells me that they had a paper document without a whole lot of follow through in it. Um, at this particular point, the hospital was owned by a company based in Texas called Tenet. Tenet at the time was the second largest owner and operator of hospitals in the United States. I am pleased to say today, Tenet does not operate any hospitals in Louisiana. Anyway, the point about the email here is a memorial administrator typed help, and they needed to evacuate 180 patients. In the civil case, a judge said the doctors didn't create that environment, the hospital created that environment, and really talking specifically about the ownership for Tenet. And this is an email. Are you telling us we're on our own and you cannot help? Again, you're the largest one of the largest hospital corporations in America, for that matter, in the world, and they were left pretty much on their own and to try and figure it out. As I say, today, Tenet either closed or sold all of the hospitals they operated in Louisiana, and they're not operating hospitals in the state. I will say, in the aftermath of that, a lot of meaningful things came out of that in terms of requiring more effective disaster planning. You know, it's unconscionable you would have a large disaster plan that didn't include how to evacuate and how to operate the hospital without electricity, or what are things that you need to do if you don't have electricity, and how do you evacuate the hospital in flooding, particularly if you're in Louisiana and New Orleans. You know, and along came Rita, and the word was to evacuate, and they wound up putting people on charter buses, and in some cases on oxygen, created an oxygen-rich environment, and one of the buses caught fire and killed 23 people on the bus. So the whole point to that is you've got to have a plan, and the plan can't be just to call buses and evacuate. There has to be more details in your plan in terms of how you deal with that. And so really the byproduct of that was to create the Pandemic and All Hazards Preparedness Act. It was a law that was to basically tie a lot of our disaster planning together, particularly from the healthcare standpoint. And so the whole point was, from an all hazards preparedness standpoint, there are common things between pandemics, and there are common things between hurricanes and tornadoes and earthquakes. And just a couple of other images about tornadoes being struck, or hospitals being struck by tornadoes. This was in Joplin, Missouri, 2011. This is a picture of Joplin, Missouri. The white that you see here is actually the sky on the other side. You're actually looking through the hospital. That gives you a side view so that you can see what I'm talking about when I say you can see through the hospital, because the hospital took a direct hit. Kind of the before and after. And then rapid evacuation. They used pickup trucks and anything they could to evacuate the hospital. There was fortunately another hospital in town that they were able to send all of their patients to. But you know, again, when we talk about disaster planning and preparedness in healthcare, it's not just hospitals. If you work in a doctor's office or a clinic or a nursing home, it's also important to have disaster planning there. This is another example. No photos, no stories, just a tweet. Blankets and medical supplies needed at a nursing home, 26th and Jackson Street in Joplin, Missouri. And then 16 were killed. Some pretty heart-wrenching stuff, but this is the picture these are some of the pictures from that nursing home. So as people were being rescued, what they did was they would pull out these mattresses and lay them out, and then lay patients that were being rescued out of the debris, they would lay them on them. And actually, ambulances were staged here, and they would come by and pick up people here. So that created a staging area, and then that created an evacuation point for ambulances to transport those that had serious injuries. But again, this is all's left of the nursing home because it had a direct hit. And just kind of a wide angle view of the damaged or destroyed nursing home. And then really one of the last things that we've come to deal with on a regular basis is the active shooter, and some of the challenges that we're dealing with it. This is just a kind of a personal experience. This was in a neighborhood close to where I lived at the time. And again, this was an active shooter at a nursing home. He was estranged from his wife and decided that he was going to go down to the nursing home where she worked, and he was going to kill her. And so as he entered the nursing home, he started going room to room, and he would, before he left the room, he would kill everybody in the room. And he kept doing that. He never got to his ex-wife, but he was confronted by a Coast Guard vet, Jerry Avant, who was able to struggle with him. Unfortunately, Mr. Avant later died was shot by the person involved. And police arrived and shot and wounded the attacker, but not before he killed 8 people. And police actually arrived in less than 3 minutes from the time the first 911 call came in. And then actually the last disaster scenario I want to give you includes the threat of fire. And the reason that fire and burn injuries are a disaster scenario that we all plan for is, hurricanes are not really a California thing, and earthquakes are not really a Louisiana thing, and tornadoes are not really a New York thing. But fire is a threat to all of us. And I use the Station nightclub fire as a great case study in terms of disaster planning and preparedness for the healthcare world, just to help us understand how quickly it can move from everybody having a good time to suddenly being a disaster. So this is kind of the floor plan of the nightclub. You'll notice this was the stage area, the dance floor. This was one of the exits, a side exit, kitchen exit, and an exit next to the performance area. A group by the name of Great White, which was the predecessor was Whitesnake, was performing, and the National Institutes of Safety and Technology, or Standards and Technology, recreated fire to understand how quickly it got as bad as it did. And so here's the fire being ignited, the flash point, 20 seconds, 30 seconds, 40 seconds, 50 seconds, 60 seconds, 70 seconds, 80 seconds. And now I've included here what the temperature threshold was like, and we'll see what flashover occurs in just a minute. So this is at 80 seconds, 90 seconds, 85 seconds is when flashover occurs. And that's when air is heated to the point that, again, there's this spontaneous combustion up at the ceiling level. And as you can tell at 90 seconds, you can't see. And even if you could, the temperature is about 1,000 degrees Celsius, which is, 1,1300 degrees Fahrenheit, obviously not conducive to life. So when we try to understand how in less than 2 minutes, almost 100 people lost their lives and another 150 people had some type of serious burn injury, I hope you can see how quickly a, a fire that occurs quickly in a confined space with a large number of people present can lead to a substantial disaster that requires surge planning for hospitals and healthcare organizations. And this gives you an idea of where the fatalities were located. We don't really have time to go through some of this stuff, but certainly if you want to go back and look through it, you can. The main solutions to it include looking at our planning, and certainly that includes surge planning and dealing with surge capacity. You know, if we look at the pandemic in Wuhan, China, they actually built a couple of hospitals over about a 2-week period. Our idea of building a couple of hospitals in New Orleans was using the convention center and building out these tent type areas. But also it worked quite effectively. We didn't wind up putting 2,000 people in it. We only wound up with about 200 people in it, but it did give us that excess capacity in case we needed it. Anyway, if we look at the last 12 months of disasters just in Louisiana, we have the pandemic, we have tropical storms, hurricanes, and severe winter weather. And you know, we wind up with all of these things that may occur, and part of this includes our planning and preparedness that we need to be prepared for and dealing with. You know, and that, kind of the next step is mass vaccination. How do we get people vaccinated so that we bring down the threat associated with a virus, and that vaccination is really the best way to control a virus. And hopefully, as I say, if you haven't gotten your vaccine, you're getting it now. But key points: have a plan. Hope is not a plan. Be prepared. Know when the environment's unsafe. It's certainly good for accreditation, but it's also good for the bottom line. Financially, your organization has to be financially well to be able to continue your mission. And so part of that includes disaster planning and disaster preparedness. But more than anything else, it's good for your employees. You know, what type of preparedness equipment do you have really depends on what you need. Most of the communities I've worked in didn't need high water rescue trucks or didn't need boats. Obviously, we're in a different environment here in New Orleans, and so you buy what you need and you use what you need. And with that, I actually went several minutes over. I'm sorry it took so long, but I hope that was helpful. Do you have any questions?
No, sir.
Well, let me go ahead and wrap up by saying this. So I'll see all of you hopefully next Monday night in class. And I think the two things that are assignments due for this coming week, again, there's a short quiz. It's about 20 questions. Just it's short time, 25 minutes. So be sure to review the content before you take the quiz, and then also the online discussion. And don't have anything else. So if you don't have any questions, I will see you next Monday night in class.
Thank you.
Thank you.
Have a good night.
You'll have a good night.